Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Golden Valley Health Center for hosting today's session, Choosing Wisely, Tests and Imaging for Rheumatic Diseases with Dr. Gerson Bernhard. Dr. Bernhard is a clinical professor of medicine at the University of California, San Francisco. He retired from his own practice in 2007 after several decades in both community and academic practice of rheumatology in Wisconsin and Northern California. And Dr. Bernhard, I am going to bring up the slide deck.
Great.
All right. Oh,
All right. Good morning, all. This is going to be our, okay, and you're controlling it, Kristen? Yeah, next slide then. Yeah, and the next one, and we get, all right. This is what I call the 4 C's of rheumatic disease immunology testing. The first of which is, next slide. Well, you can put them all on if you want. They're complex. They're not easy, simple tests. They're done in all the commercial laboratories, to be sure, but they are complicated. They are often confusing because you get a result and you say, well, what does this really mean? If I see a positive ANA, is that important? Is it not important? Or does it make a difference how it's done? Does it make a difference in terms of the titer, etc.? And by and large, all these tests are confirmatory. They are not by themselves diagnostic. This is, somewhat different from a situation where you have a patient whom you suspect has diabetes, you get a blood sugar and a A1C, and that says, yep, your clinical suspicion was right, and here it is. Or if it's somebody who has a renal insufficiency and they see your elevated creatinine, you say, yep, it's as advertised, so to speak. And the same could be for certain endocrine testing, such as thyroid. This is not generally true, with a few exceptions that I'll go into a little bit later, for any of the immunologic tests that we use for rheumatic diseases. And they're costly. So if you're concerned about how much money you're spending from your clinic amount of funding, this becomes an issue. So with that, let's go forward. Next slide, please. So to focus in on this, the most important things that you can do, and I know this takes time, and time is of the essence, and the amount of time you have per patient in a fast-moving, busy clinic is very limited. If you get 10 to 15 minutes, including your recording of all your information, that's considered good, and very often I know you're running behind. Nevertheless, patients who come in with rheumatic complaints, particularly those who have rather chronic rheumatic complaints, not the ones who have an acute episode, you really need to get a good background history. If these are return patients, you already know a lot about their general lifestyle, you know about their comorbidities, but amongst the things you want to know is, what's the functional impairment? What kind of problems is this particular articular rheumatic disease induce in you? What has happened and how long has it been there? And if they tell you, well, my joints hurt, you'll have to then get more specific and history. Where, which joints? Does the joint pain wake you up at night, or are other things waking you up? So that you begin to discriminate a true inflammatory rheumatic disease from something that is different. Could be really the rheumatic symptoms of connected other diseases, even endocrine diseases such as diabetes and hyper or hypothyroidism, etc. Then on your physical examination, get specific. And this is the information that we, when you ask us for consultation, want to know. We want to know a lot more about the specific joints that are involved. Are they painful and tender? Are they swollen? Is there a lack of motion or a limitation of motion, etc.? If it's muscle problems, is there identifiable, somewhat semi-clinically quantifiable weakness, etc.? So get a really good clinical background, then begin to say, well, now what do I need in the way of testing to begin to screen this out diagnostically? Next slide. So when you're beginning to choose your tests, the most important ones, I'm sure, are diagnosis. Why am I getting this? Does it really help me in a diagnosis? Some of the tests we're going to talk about are good for predicting course or getting some sense of outcome. Examples of that might be if you got a anti-CCP and you said, oh, it's positive and high titer, this begins to tell you automatically, yes, I have a patient with rheumatoid arthritis, and the course is going to be sort of the standard course of rheumatoid arthritis, and the outcome is going to be very dependent, but it is not something you want to keep repeating because it's not going to vary in the course of the disease. And also, these tests will help you in your choice of therapy. So you can get somewhat of a positive predictive value out of this. And again, the issue is choosing on the basis of cost. You can get a lot of very sophisticated immunologic tests for rheumatic disease, and you get a lot of very sophisticated imaging, but at what cost? What's the cost-benefit ratio? Next slide, please. So there are a bunch of non-specific tests that I think you need to pay attention to. And very often I find when people send consultations to us online, they don't include some of these results. Yes, they may include a CBC, which will tell us a lot. Certainly, we want to know something. We want to know creatinine because I want to have a pretty good sense of renal function and the general chemistries, of course. What is often lacking, I find, is a urinalysis because you need to know whether or not there is any evidence of urinary tract involvement, infection, but more importantly, whether there's renal disease itself, inflammatory renal disease. And then the acute phase reactants, sed rate, CRP, and remember a platelet count, an elevated platelet count is very often a marker also of inflammation. So if we see that the patient is somewhat anemic, may have a modestly elevated white count, has a normal urinalysis, has a positive elevated sedimentation rate and or CRP, and has a polyarthritis, which is localized to small hand joints and small foot joints, with clinical signs of inflammation, then you've got a focus and saying, aha, I need to know more specifically about this, and we can go on. I would also urge that you get a synovial fluid whenever it is feasible and reasonable. And it's not hard, really, to aspirate a knee. Knees are big joints. If a knee is really swollen, you can easily get fluid out of it. It's the procedures are well outlined online. It's almost a slam dunk, if you will. There's some other joints that is much more difficult. Yeah, wrists and elbows and ankles are a little more selective. But you don't necessarily have to send the patient to an orthopedic surgeon who will aspirate the knee joint. A knee joint is something you can do easily in the clinic, and you get some fluid, which will tell you a lot, particularly if this is a patient who has a big swollen. And obviously, if they don't have swollen knees, then all that it doesn't apply. And if you get fluid, look at the fluid itself. Normal joint fluid is like what I call a number 10 oil. It's clear, it's slightly yellowish, it feels a little oily to the touch. And if you do have a laboratory, you can do a cell count on it, there'll be very few cells. If it is cloudy, that almost immediately tells you there's an increased cell count. That means inflammation. And then the question is, am I looking for crystals such as urate crystals or pyrophosphate crystals? Or am I looking for evidence of infection? And that's why the polarized microscopy that you should request of the laboratory is important. Next slide, please. Now, what about the survey immunologic tests? Very often I see a consultation of a 35-year-old woman who comes in and now is having several weeks of articular symptoms. And very often I do not see a good description of which joints are involved and how long this has been going on, what the patient has done for themselves to control the symptoms, and a good clinical background, as I mentioned before. And very often I'll see in the laboratory studies a positive rheumatoid factor. Well, it's true that 70% of patients with rheumatoid arthritis are going to have a positive rheumatoid factor. And as I shall show you in a few minutes, there are also a lot of other diseases or disorders, and even some normal people who will have a positive rheumatoid factor. It is not specific. By contrast, if you look at an anticyclic citrullinate protein, we now think this may really be the antigen that stimulates the immunologic response called rheumatoid arthritis. And it is much more specific. And there are very few false positives. And it is positive in approximately 85% of patients that we clinically classify as rheumatoid arthritis. There is some discussion as to whether or not those patients who are so-called seronegative don't have either a positive rheumatoid factor or a positive anti-CCP, whether that's really truly rheumatoid arthritis or some other inflammatory arthritic disease with a different course. I often see the anti-nuclear antibody comes back positive 1 to 80 or 1 to 160. And with a question of what do I do with this? It's true, the vast majority of patients with systemic lupus erythematosus do have a positive anti-nuclear antibody. And there's sometimes, if you have it done by an immunofluorescent test, it is fairly specific for lupus, but it is also present in a lot of other connective tissue diseases and some other disorders, even in normal people. And one of the benefits also, and I'll show you some patterns of it, if you get a anti-nuclear antibody test that's done by immunofluorescence, they will report a titer and they will report a pattern, an immunofluorescent pattern. And that's sometimes of some use in subsetting which kind of inflammatory connective tissue disease we are looking at. A good survey is the VDRL is there any question at all about antiphospholipid syndromes. These are false positive VDRLs, and if they're negative, and there's no good clinical evidence, you can move on. The serum uric acid is frequently reported as part of the general chemical response report. But remember, it is not specific to gout because it'll be elevated in renal disease and some other disorders, particularly lymphomas, etc. So, and it may be elevated also in patients who are on diuretics such as hydrochlorothiazide for their hypertension. So that is fine and helpful in gout, but it is not specific or necessarily diagnostic. And that's where, if at all possible, if you can get fluid from the joint of a patient who comes in with a relatively acute arthritis, obviously again of the knee, you can see those crystals, and that indeed is diagnostic. And I'll show you some evidence. I'll show you some examples of that. Next slide, please. Let's go back to that rheumatoid factor. As I said, on average, 60 or so percent of rheumatoid arthritis patients will be positive. But look, Sjogren's syndrome, high percentage positivity, mixed connective tissue disease, mixed cryoglobulinemia, even in SLE, a modest number of patients with poly or dermatomyositis, in chronic liver disease, and even in the aged normal population, we see a modest percentage of positive rheumatoid factor. Next slide. And here is a whole bunch of non-rheumatic diseases in which you may see a positive rheumatoid factor. This is all to, again, to explain to you that it is not specific for rheumatoid arthritis. If the patient comes in and has classic clinical features and a positive rheumatoid factor, that might sway you diagnostically. But just remember, there are other causes for it. Next one. Next. Now let's look at the ANA. It's a nice survey test, as I said. 98% of patients with SLE, drug-induced SLE, also will have a positive ANA. There are other rheumatic diseases, even in rheumatoid arthritis, a modest number, and Sjogren's syndrome, scleroderma, mixed connective tissues, vasculitis of all forms. We often see usually low titer positive ANAs. There are certain viral infectious diseases in which you can see a positive ANA. In chronic hepatitis, biliary cirrhosis, certain malignancies, especially leukemias and lymphomas, in multiple sclerosis, autoimmune thyroiditis, all of these can have usually low titer positive ANA. So again, the ANA is not specific for LE. It may only mislead you unless you have a good clinical story to match up with it. Next. Now here's some of the patterns. This is the so-called RIM pattern. Usually that suggests that there is anti-DNA antibody present. And this again is much more specific for SLE. But look at these. These are rather diffuse patterns. There's a spotty pattern. There's another diffuse pattern. These are not specific, and they contain a variety of autoantibodies. They may be positive in LE, but on a lot of those other rheumatic diseases that I described, and even in some of the non-rheumatic diseases. So patterns themselves are sometimes useful, particularly if we can see this rim pattern. Next. So if we get to the point where you're pretty sure that we have an inflammatory rheumatic disease, and it's not just plain straightforward rheumatoid arthritis, and it's not a metabolic rheumatic disease such as either chondrocalcinosis or gout, and you think we're dealing with one of the inflammatory diffuse connective tissue diseases, then the subserologies, which I would consider tertiary tests, become important. And here is just a smattering of a wide variety of tests that we as rheumatologists like to see.
Can I help you?
Pardon me? Uh, we as rheumatologists like to see results on if we're going to subcategorize and begin to plot out a treatment regimen. By and large, these are not tests that primary care people need to order. This is the sort of stuff that the rheumatologist wants after we've concluded that indeed the patient has an inflammatory rheumatic disease and in this general category. I would point out that a lot of times people want to get an HLA-B27 to exclude inflammatory back pain. That's not going to be very specific. Yes, it's true in patients who have ankylosing spondylitis, there's a high percentage of those patients who are positive HLA-B27, but it also occurs positive in about 8% of the white population and a somewhat lower percentage of Black and Hispanic populations. So, and it also is positive in a modest number of other inflammatory rheumatic diseases such as psoriatic arthritis with any back involvement, but not in the same percentage. In other words, 30–40%. So it's not very specific. It is not diagnostic. And however, the B5801 is important if you have a patient who is going to be on treatment or you're considering treatment of their hyperuricemia and gout with allopurinol. Patients who are B5701 have a high risk factor for developing adverse reactions to allopurinol, and those patients should not receive that drug. We can discuss any one of these along the way. I would point out that, for instance, this group of sub-antibodies are related to inflammatory muscle diseases. This becomes important to us as rheumatologists to try and subset, if you will, the type of inflammatory muscle disease and begin to set some treatment plans and some parameters for prognosis. Next. Now, in the synovial analysis, we talked a little bit about that again. You want to know something about the color, the clarity of it, the cell count, and its differential. And if there's any question or suggestion that maybe this could be an infection, then the grand stamen culture. Unfortunately, unless you've got a rip-snorting, acute pyrogenic, pyrogenic infection, your gram stain or culture are not likely to be positive. It's useful if you're concerned about things like gonorrhea. And the crystal examination with compensated polarized microscopy. These are the things you want to ask your laboratory to be sure to do, and put that fluid in some tubes that have an anticoagulant and tell them which anticoagulant you used. Next slide, please. And here's the sort of thing that they may report or you see. You see this nice crystal, it's negatively birefringent. If you look very carefully at this slide, it's within a cell. It's the intracellular crystal that is diagnostic of acute gout. Next slide. By contrast, you see this somewhat blue stubby crystals, and I won't go into the issues, details of polarized microscopy, but they look differently and they are identifiable. And again, if they are present, especially intracellular, with an inflammatory, relatively acute arthritis, this is pretty diagnostic. Next. Now let's quickly go over the issues of imaging. What to order and when to obtain it. Plain films may sometimes, they're not very good to show early inflammatory rheumatic disease, such as rheumatoid arthritis. If the patient comes to you and has a past history of possible rheumatoid arthritis, may have been dropped from therapy, disappeared from treatment, etc., and now comes back, yes, now you want to be able to see the films of the involved joints and see if there is any significant damage. And which films should you be getting? I would say, if you're concerned about that, hands and feet for RA, knees and weight bearing, which should be weight bearing knees for osteoarthritis, an AP pelvis if you're looking or questioning inflammatory spondyloarthritis. The only time you really need spine films, which have a lot of radiation in them, is if you're concerned with fracture or malignancies or infection. So if there's a doubt and you're not really concerned about it, don't get the full spine films. Simply get the AP pelvis to tell you whether or not there's been erosion of sacroiliac joints that are consistent with inflammatory spondyloarthritic diseases. I like to have patients who are going to be seen for some time and treating get a chest film. Why? Sometimes this is diagnostically beneficial because remember, lupus, rheumatoid arthritis, dermatomyositis, scleroderma are systemic diseases. They're inflammatory, destructive systemic diseases, and they do often involve lung. But more than that, I want to also know if there's any comorbidities. If you have a patient who probably has rheumatoid arthritis, or you already know has rheumatoid arthritis, and you're going to be treating them with the usual the disease-modifying agents that we currently use, you want to be sure that they don't have any significant comorbidities, not the least of which is tuberculosis. Initially, an MRI is not terribly useful. So even if you have a spondyloarthritis, if you have an absolutely normal pelvic film and you don't have evidence of inflammation via clinical features as well as a SED rate or CRP, I would be selective and not order an MRI. The CT is most useful in rheumatic diseases for soft tissue lesions. And an MRI, with one exception, an MRI is often useful, and we like to get more sophisticated about it if we think there is a myositis present. So with that, this is a quick survey of some of the tests and imaging that I would consider that you people should be have some familiarity and comfort with, and let's see how that would apply. As an example, we say you have a patient who comes to you for the first time with a story of the last 6 or 8 weeks, and she's about 35, and she says, "I got joint pains, I hurt all over," and you got a good clinical story that, well, yes, the joints actually wake her at night, the joints are stiff in the morning, and she can point to specific joints that are involved, i.e. wrists, my MCP joints, PIP joints, maybe some foot joints. And if that, by the way, you have to ask specifically about foot joints in terms of, have you had to change your shoe size and things like that? Is it difficult to walk, etc.? And on your examination, you find that yes, indeed, some of those joints that I just mentioned are actually tender. Maybe some of them are swollen. They may be modestly limited. With that in mind, then go and get the survey tests. If that comes back, yes, indicating evidence of inflammation, proceed beyond that and get the additional more specific immunologic tests that we reviewed. By contrast, if you got somebody who's in her, say, their mid to late 50s or early 60s, who comes in and primarily tells you about joint pains over a period of time that are beginning to limit their ability to walk or stand, etc., and your examination does not necessarily find much in the way of inflammation, but perhaps some bony enlargement around the joints and maybe some limitation of motion, again, the survey tests, and then that may lead you to some more specific joint films, and a diagnosis can be made, and then you can set out a treatment regimen. What I'm really saying to you is, look at that patient, get some survey tests, and then if you're still concerned, let us know and give us that information, because we can further direct you and so that we can be more specific. I know that very often you'll say to me, well, I would like to refer this patient to rheumatology, but I'm not going to be able to get them in until next 4 months from now. And that is a frequent comment. So in the meantime, you need to do something specific for this patient, but you need to have a better sense of the diagnosis. With that, I will take any questions or comments.
Thank you so much, Dr. Bernhard. This is fantastic. I don't see any questions yet, but remember that you can put your questions into the Q&A box or the chat box. Use the raise hand feature to speak directly to Dr. Bernhard about any questions or maybe even a patient case that you'd like to review. And while we're pausing and waiting for those questions to come in, I'm just going to remind you that that when you close out of this webinar, your CME survey will appear in a tab on your browser. You want to click that and then complete the CME certificate, the CME survey. You should receive your certificate almost immediately if you have the correct email address, correct speaker, Dr. Gerson Bernhard, and the correct date, December 6th. I can keep rambling until we have questions, but oh, there we go. All right. If we are having concerns about a patient having possible RA but unable to see a rheumatology soon, can we start methotrexate ourselves?
That's a very good question. Let's go back to the diagnosis. Let's be sure that this patient has RA. How do we make sure? The clinical signs and symptoms, of course, elevated sedimentation is a mark of inflammation, the general survey of their general health, and if you can, the positivity of preferably anti-CCP, but secondarily rheumatoid factor with the exclusion of other systemic inflammatory rheumatic diseases. So if you come to the conclusion that, yeah, this patient has rheumatoid arthritis by all counts, but I can't get them into a rheumatologist for a while, can we start methotrexate? The answer is absolutely. Why not? And if you're going to start methotrexate, make sure that you know something about this patient's liver function, that you know something about their dietary and especially their alcohol habits. There are those who would say, oh, you cannot give a methotrexate to any patient who drinks even one alcoholic drink a week. That's too, I think, too rigid. The data does not support that. However, on the other hand, you don't want somebody who is knocking off 3 and 4 drinks or a bunch of beers every day, because their risk of developing hepatic disease as a consequence of the combination of methotrexate and alcohol is appreciably increased. So yes, make sure that they limit their alcohol to a very minimum amount. And yes, you can start methotrexate. There's an argument about whether or not we should start parenteral methotrexate because you get better and more consistent absorption, or whether you can start orally. Obviously, the easiest way is for the patient and for the prescriber is to start oral. If that's the case, you're either way, your ultimate therapeutic level or goal is to be between something like 15 to 20 milligrams once a week. And you don't want to start up at that level. So we try to test them out with perhaps 7.5 or 10 milligrams. These are 2.5 milligram tablets, or you can get them and teach them how to self-inject if you choose to use the subcutaneous approach first. Nevertheless, you're talking 7.5 to 10 milligrams once a week for a couple of weeks to make sure that they don't have any significant adverse reactions. Then move on up to 12.5 for a week or two, then to 15 for a longer period of time, and make sure that they also take 1 milligram daily of folic acid to protect them because this is an anti-folate agent. Monitoring them is very simple: blood count and a liver panel, perhaps in 4 weeks after starting. And after that, every 3 months, it looks like it's sufficient. By the time they get to the rheumatologist, then you have that kind of information already. And by that time, you also had an opportunity to see them clinically and see whether or not the duration of morning stiffness has come down, the number of swollen tender joints has come down, whether they're feeling much better, whether they're sleeping through the night without joint pain waking them, and whether their sedimentation rate and or CRP have come down to something either normal or near normal. So that gives you a lot of information. It moves the patient treatment program further along. And by the time they see the rheumatologist, that helps the rheumatologist in terms of deciding whether or not to perhaps increase the methotrexate, continue the methotrexate, or add in or shift over to a biologic agent. Again, you don't need to have joint films if it's a fresh rheumatoid arthritis patient. But if this is a repeat or a long-term, that would be useful additional information as well as the chest film. I hope that explains or gives you a clue about how to proceed.
Thank you so much. It's a great answer. Next question, how would you differentiate differentiate a patient with known RA from having acute RA flare versus possible septic arthritis if one joint is involved? Need to do synovial analysis?
We need to do blood and synovial analysis because if there's a joint involved, obviously there is bacteremia to get there. So I shouldn't say obviously, but probably there's bacteremia to get there. So ideally, yeah, synovial analysis. The probability is if that patient has not had excellent suppression of all the inflammatory characteristics and laboratory markers of a rheumatoid arthritis, and has not changed their medical regimen, and now comes back with just one joint, I would be very suspicious that this may represent a septic joint. But again, it's going to be the history, and absolutely, you need to be able to get the fluid. If it happens to be a joint that you're not comfortable aspirating yourself, like it's not a knee, it's not a wrist or an ankle, then indeed you may need to get one of your orthopedic friends to aspirate it for you and make sure about the usual features that we talked about: cell count, gram smear, uh, culture, etc. Does that answer your question?
I think so. If it doesn't, please feel free to type in some more and we'll circle back to it.
Good, good.
I don't see any other questions, but we can pause and wait.
All right. I hope that what I ran through rather rapidly was sufficiently clear. What disturbs or distresses, I think, most of us in rheumatology is that we get a patient with, I get a referral from one of the clinics with scanty history, not a lot of physical examination. Yes, general examination, but not musculoskeletal exam that's useful. And maybe not a good skin exam because some of these rheumatic diseases are well manifest or have as clinical features a lot of skin dermatologic features. So, and then we get an array of laboratory tests with questions of what do I do with this information? And the array of laboratory tests is beyond sometimes very difficult to interpret in that setting. If we have more clinical background in detail, and then some of the basic laboratory tests, we can say, okay, next step in the laboratory and or imaging, etc., is A, B, and C, and let's keep the dialogue going. And yes, this is a patient you should refer, or no, this is a patient you don't have to refer. Here's what it seems reasonable to proceed with. And then if things aren't going well, you can talk about referral.
All right. We have a few more questions. Can you explain the ANA pattern again?
Yeah, by immunofluorescence, different autoantibodies give different patterns. And sometimes the laboratories will report if they're doing it by immunofluorescence, will report a pattern, and they'll say it's a rim pattern, or it's a small speckled pattern, or it's a large speckled pattern, or it's a diffuse pattern. And there is a rough correlation of those patterns with the specific autoantibodies. The most definite one is the rim pattern, which shows this nice, clean immunofluorescent rim of the cell. And that seems to associate very much with anti-double-stranded DNA antibody. And that tends to be rather specific for SLE with renal involvement. Uh, some of the other patterns are not quite as specific, and I wouldn't get too worried or hung up about that because it doesn't necessarily define uh, what the precise disease is. It gives you some clue, it gives us some clue, but that's about the extent of it.
Great. Okay. Would you approach, okay, would you approach to your workup for RA be different from a potential pediatric onset of juvenile onset RA?
Yeah, in some respects, this is true because the juvenile onset sometimes presents with very few joints, but a lot more systemic disease, sometimes with rash, which is rather evanescent. Sometimes it's just what we call pauci-articular disease and a positive ANA. Some of these, and this is more common in adolescent girls, and that the course of that disease tends to be rather benign, and they often outgrow this when they get to be adults. But it also suggests that there may be another lurking, if you will, rheumatic disease. And given a child, 8, 10 years old, comes in with classic polyarthritis, bilateral symmetrical, positive anti-CCP, this is rheumatoid arthritis as we see in the adult. And one of the other things that is sometimes confusing is you may see a adolescent boy come in with a few joints that are apparently inflamed by history and by clinical exam, elevated sedimentation rate, negative rheumatoid factor, negative anti-CCP, and you're saying, is this rheumatoid arthritis? Or is this the first episode of their having a ankylosing spondylitis? At that point, interpreting a AP pelvis film is exceedingly difficult. Only the very expert people can do it, and sometimes it's at that point of disease, there's nothing abnormal. So those patients, and these, as I said, are usually adolescent boys, may very well have inflammatory spondyloarthritis. And treating them with a nonsteroidal anti-inflammatory drug may be quite adequate.
How important is titer level for the ANA, and at what level is most likely a true positive for SLE or other rheumatic conditions?
Most laboratories will report a positive ANA at a titer of 1 to 40. And that gets to be a sort of the equivocal level. 1 to 80 is the next step up because it's a twofold dilution. And here again, it's sort of equivocal. Most patients who have frank systemic lupus erythematosus will have higher titers than that, 1 to 160, 320, 640, or even higher. That may not be true for patients with rheumatoid arthritis. They'll have low titers. It may not be true for people who have false positive ANA. They'll be generally low titers. When you get to patients who have scleroderma, dermatomyositis, Sjögren's syndrome, we'll get sort of mid-range titers. So there is nothing very specific about it. I'd like to say to you, there's a cutoff point. If it's below 1 to 160, don't worry about it. That would be very nice. Unfortunately, that doesn't necessarily hold up. And that's why using the testing doesn't give you all the answers. You have to match that up with the clinical features and the pattern of disease that you see, and then say, yeah, I think this patient really does have SLE or Sjögren's syndrome, et cetera, or dermatomyositis, et cetera. And that's where you go beyond with further laboratory testing and or referral.
What is the preferred initial NSAID medication preferred to ankylosing spondylitis? I know I said that wrong.
Any NSAID is fine. There's nothing that's really preferred. In terms of if you think you're going to have a patient who is going to be treated with full doses of a nonsteroidal anti-inflammatory drug, then you want to be able to choose one that has the least chance of, I should say, a lower chance of producing some of the complications, i.e. ulcer, because ulcer is indeed the risk of ulcer is indeed increased with chronic use of a nonsteroidal. So for that, by and large, we've been choosing celecoxib or meloxicam, but any of the nonsteroidal agents will work quite well. You can start off with any one of them that you want, even OTCs, like you can get naproxen over the counter. And you can start off with that and use that for a few weeks and get a sense of whether or not it's effective. Again, if you're using it to try and determine or start a treatment program, it's got to be consistent, and the patient has to understand that they can't miss doses, and then you're going to have to be able to report. They're going to have to report back to you both by clinical features, their back mobility, the absence of night pain that wakes them, clinical markers like sedimentation rate or CRP. Radiographic changes will not, there isn't going to be a significant radiographic change, so don't go there.
Thanks, Dr. Bernhard. I don't see any more questions, but we'll just pause one more time. We have a few more minutes, so if you do have any last minute questions, please feel free. But in the meantime, Dr. Bernhard, thank you so much. This was fantastic.
I hope this helps everybody in the primary care situation, because sorting out connective tissue diseases, putting them into two major categories, those that are inflammatory related to other disorders and those that are not. Also remember, I know that a lot of patients from whom we get consultations have comorbidities, not the least of which is obesity, chronic lung disease, diabetes, very prominent. Yes, endocrine diseases do have musculoskeletal manifestations. Malignancies sometimes have musculoskeletal manifestations. So,
Oh, we have two more questions.
okay.
What is a specific dose of oral steroid would you use for acute RA or SLE flare?
Well, the lowest dose that is effective is the one you want. For most patients who are on a regimen for, let's say, rheumatoid arthritis, assuming that they're taking their medications with regularity, and now seem to be exacerbating because it's post-infection, post-operative, something has happened in their in their life to unstable things, and you think it's going to be temporary, then 5 to 10 milligrams of prednisone each day usually takes care of it. It gets it settled down, keeping up the background medication. If it's a more profound or persistent problem, then you have to sit back and say, wait a minute, I need some help here. Do we change medication altogether? Or is there something else that's going on? i.e., has this patient now developed a malignancy? And I can recall a number of patients I've had in the past who were under control with the rheumatoid arthritis on methotrexate and suddenly had a flare. And it was sort of unexpected. And they were very compliant patients with no significant adverse problems and no significant comorbidities. And the real issue underneath it was that they had developed a lymphoma. So you have to be always alert. Now, for SLE, that's another story. Here we're talking about patients who may be well controlled or reasonably well controlled, and ideally we like to get them off of corticosteroids altogether and use other agents. Those patients sometimes require, if they have a real flare, let's assume we have a patient who has under control with anti-malarial medication and maybe an anti-inflammatory drug for their arthritis and their skin disease, and they're doing all the proper things to take care of their skin. They're not having any pulmonary problems, etc. But now they're suddenly changing. Things are changing. And you find out that now they have proteinuria and maybe their creatinine has risen a bit. Now they have renal involvement. Yes, that patient's going to require larger doses of corticosteroids and probably a renal biopsy and on into a whole additional regimen. And that patient should be managed, first diagnosed fully, and then managed by rheumatology. So if you do need to start an increase, usually lupus flares will come under control with about 30 milligrams of prednisone daily. Again, you don't want to carry it on for a long time for all the reasons of adverse effects of corticosteroids and the fact that it's not curative.
So I think this last question actually just goes hand in hand, and you probably have answered it, but I'll still ask. Is there a role for steroids to treat the inflammatory component in addition to the NSAIDs?
This is debatable. There are those in rheumatology who would say, oh, I've got this patient on rheumatoid arthritis with rheumatoid arthritis. They're on a modest dose of an anti-malarial agent, and they got them on full doses of methotrexate. And their disease, by and large, is going well. They don't have a lot of morning stiffness. Their SED rates are normal or minimally elevated. Number of joints isn't bad, and their function's pretty good. But if they took 5 milligrams of prednisone a day, they're good to go. They're fine. They're feeling great. They function well. And at 5 milligrams, you say, well, what's their relative risk? Risk of infection, risk of TB, risk of osteoporosis. And that's probably very low. It's correlated with the dosage, but it is not zero. So by and large, or if on the other hand, this is just a temporary flare, 5 to 10 milligrams in the morning doesn't really disturb their ability to respond to infections or trauma. In other words, their adrenal responses are still pretty much intact, and that's okay for a relatively short period of time. Ideally, you want to get them down below 5 milligrams a day off if possible.
Thank you so much. I know we're 2 minutes over, but there was one more question, I swear. Last question. If
Okay.
you do have to hop off, please feel free. But
No.
what is your stance on use of opioid therapy for pain management for OA or inflammatory arthritis?
Uh, you know, this is usually for osteoarthritis. Somebody who's coming along and has, let's say they have a bad knee or a bad hip, and they're saying, "Oh, I've tried the Celebrex up to 400 milligrams a day. It doesn't do any good, or it's not enough. Still waking me at night." I would then look at that patient very carefully and say, "Well, have we reduced your weight to ideal?" Because weight and as far as lower extremity joints is a very, very important issue with any kind of destructive arthritis, whether it's late stage rheumatoid arthritis with secondary osteoarthritis or primary osteoarthritis. And if you're going to use an opioid, then very selectively, not as a chronic thing so that you can so-called get by. I can understand people doing that so they could perform a particular task or for a period of time, or tide them over before they're going to have an arthroplasty. Uh, there are a few situations in osteoarthritis where chronic use of a low-dose opiate seems reasonable, appropriate, but those are really scant. As far as rheumatoid arthritis, I would say any inflammatory arthritis, no, there are other ways to treat this. You can use the opioid transiently, but only transiently.
Dr. Bernhard, thank you so much. This was fantastic. Great questions. And thank you all for joining us today.
Thank you all. Have a good day.